ROP here, and we're going to the other end of the age spectrum here with PCV. But the only common line that I can draw is that we all face the same challenges of follow-up, cost, and compliance. And we all know that the treatment of choice would possibly be antibiotics, repeated antibiotics, but that is not possible in all cases. So I'd like to talk about some alternatives. So I think the picture speaks 1,000 words, and we have this patient in 2022, had been advised multiple injections elsewhere, refused multiple injections, with a large polyp just temporal to the fovea. And said, she came and told me, I'm willing to take 3 injections and nothing more. I do my best. And this is probably around the time that my journey began. I did an angiogram and I found that there are polyps well away from the center of the fovea. So if there are multiple polyps, superior and temporal, I'll go through it quickly. And I'm sorry, I'm going back. Yeah. And 2 weeks after the anti-VEGfs, this is the picture, the OCT picture that you see, that we have a polyp which is temporal to the fovea and nothing in the fovea. And then I laser this, a confluent laser was placed just temporal over the polyps. There's still some subretinal bleed over there, but because the polyps have regressed in size, I'm able to apply laser at a relatively lower power than I would have been able to. So this is an example, just an example of when we tried to use laser as an adjunct. Now, as I started using laser as an adjunct more and more, mostly out of financial issues for the patients, I decided to just collect the data that I've had among the patients I've used. So we're facing a lot of challenge with having the withdrawal of BDT, which is an excellent choice for extrafoveal lesions. We have financial constraints and demographics and diagnosis also. And in my particular collection of patients, we've got constraints of different antibiotics being used, a non-standardized regimen, and a lack of a control group. So quickly, some more pictures. This is another patient, Feb 2021. 624 parts. You can see that there's almost a clover leaf-like pattern of polyps all over the fovea, all over the macula, including the submacular region. Angiogram baseline showed multiple polyps, including at the fovea. 1 injection later, there's still fluid. I did laser to the extrafoveal lesions alone, despite the fact that there was still a subfoveal component. Visions now improved to 6/18. Again, an angiogram and a second laser in 2022 for this patient getting multiple injections. Now, if you look at the fovea is clear. The fovea doesn't have any polyps. The fovea does not have any fluid. This is when I completed the laser, and 1 year, now the patient's on PR, and the patient's got a best corrected regularity of 6-9 parts. Now, this is the reason why I put this case is because it's such a great outcome. Most of our patients did not have such a fantastic outcome. But it is possible. Even in patients that seem a bit hopeless, it is possible to reduce the number of injections in extrafoveal lesions, get them to regress away from the fovea before you laser them, and destroy the existing polyps, the remaining polyps with laser. So this is another patient who had a polyp supranasally, a lot of fluid. I did laser for this patient, but there was recurrence. And then I shifted the patient to Peginix and augmented the laser. And after that, 2023 onwards, this patient's been on TRN with a vision of 6/6. Another large polyp at the center of the fovea, right in the center of the fovea. Gave a few injections. It regressed away from the fovea, and it is now a juxtafoveal polyp just inferior to the fovea. After a little bit of laser just at the edge of the fovea, we can see that this patient's now on PR, patient 6/9, on no injections for the past year. I have a total of 18 patients which we collected, and I gave an average of 2.38, so that's probably 2 to 3 injections before the first laser, and 3 injections after the laser. And we had an average visual gain of 2.7 lines, and we had 4 out of 18 patients requiring more than 1 laser. Each laser was preceded by an angiogram. The settings I used was a very low duration, 30 to 40 millisecond duration with 150 up to 200 milliwatts power, depending on this amount of fluid and the size of the polyp. And I applied, if you look at the pictures there, they're confluent applications of laser. So one spot overlaps the other. It's like painting the lesion with had 6 recurrences out of 18 patients, and the average time to recurrence was 3 months, and we had multiple recurrences in 3 out of 18 patients, which we shifted to VEGf. And the patients with recurrences had a much poorer outcome. So when we have 2+ lines of visual gain in the ones that did not recur, these patients, despite shifting to VEGf, had only 1.5 letter gain in vision. Now, to compare, there is a study where anti-VEGF was used as an adjunct. So basically, first you laser the lesions, and then you give anti-VEGF for those who do not improve. And as you can see that they achieve stability in 50%, but improvement in only 25%. And this was ICGA guided in non-treatment naive patients. And they gave, in the end, 3.66 injections and 1 to 3 sittings of laser. So if you look at it, I would say that this is a suboptimal outcome compared to giving anti-VEGF first. And as time has gone by, I think we have started giving anti-VEGF for the disease first, whether it's DME, whether it is a BRVO, before we shift to giving a grid even at any point of time. We have all shifted to using laser as an adjuvant rather than laser as a primary treatment. And I think by shrinking the polyps, as you look at the photographs, by shrinking the polyps, getting them to move away from the center of the fovea, we can provide better visual outcomes, a quicker resolution, and a reduced recurrence, especially in patients where we can get the lesion well away from the fovea. If I'd be happy to take some questions if there is time, but I think we're running short of time.
Yeah, thank you.